All right. So, hello, everyone. I am Dr. Kendra Batchelder. I'm the founder and CEO of Medara, where we're developing AI to forecast future disease, starting with breast cancer. So, we are very excited to bring together experts from across the healthcare ecosystem, across technology, clinical, and also industry to discuss how AI or artificial intelligence is really transforming breast cancer care from everything from improving early detection to enabling personalized risk prediction and more proactive screening strategies. So thank you all so much for joining today, and I'm especially grateful for our speakers. So we have Dor, Imran, and Dr. Traill, who I will ask to introduce themselves in just a minute. But briefly, Dr. Traill is a breast radiologist with expertise in AI, and I think he's really seen everything through the transition from traditional algorithms and approaches used in clinical practice to kind of the new and emerging technologies that are coming out. Imran is the Chief Commercial Officer at Alliance Medical and also doing some very interesting work that we were just talking about in the health economic space, I'll say. And then Dor is a dear friend and human brand expert for AI, and I'm very grateful to have her input on this conversation as well.
Thank you.
Just a little bit of background. So breast cancer remains as one of the most significant health challenges facing women worldwide, and not only for women themselves, but a diagnosis also comes to impact on their families, as well as their communities. And really, I think the case is now really being built up to has a much larger effect, on economies as a whole. If we look here in the United States alone, more than 300,000 women are expected to be diagnosed with an invasive breast cancer this year, and nearly 40,000 will lose their lives to the disease. So when we take all of these numbers that come out each year, 1 in 8 women in the US particularly will develop breast cancer in their lifetime. And then if we look globally, breast cancer is the most commonly diagnosed breast cancer worldwide. I will say, if there's good news, is that breast cancer, when detected early, the 5-year survival rate is extremely high, which really highlights the life-saving impact of early detection and timely intervention. Yet we are still finding a significant portion of breast cancers at a later stage as well. So today's conversation will really explore the technologies driving advances, how AI is helping clinicians make more informed decisions, and why this shift matters not only for patients, which is really at the center of what all of us do, but also for the healthcare system in a way that earlier detection and more personalized care really has the potential to, improve the outcomes, but also reduce unnecessary procedures, lower costs, and ultimately help all of us save lives. So with that, we'll have the speakers introduce themselves briefly, and then we can jump into the questions. So Dor, did you want to go first? And then Dr. Traill and Imran?
Sure. Thank you, Kendra, and hello, everyone. I'm Dor Lata, founder of Media Spotlight Coaching and creator of Command the Camera and Human Brand. For more than 20 years, I've worked in executive presence, media, and leadership development, including 12 years as a creative director for Bloomberg TV Global Operations. As a breast cancer survivor, this conversation is deeply personal to me. I've learned that innovation creates the greatest impact when people trust and understand it. I'm excited to explore how technology, communication, and human connection can help shape the future of breast cancer care.
Thank you.
Hi, everyone. Again,
Thank you.
thanks also for the invitation. I'm really looking forward to this discussion, my favorite topic by far. I have practiced radiology for over 35 years. I'm a breast specialist, obviously have had a lot of frontline exposure. I also had a prior role as a KOL for iCAD Medical, which has since been bought out and doesn't exist as a separate entity anymore. But in that role, I was a clinical advisor, and I was also involved with a lot of client calls where we would discuss the technology, what it could do for the potential client, and how the client can implement the technology. So I have a lot of insight as to what the pushbacks are, what the holdups are, et cetera. Um, and because of that, I have used AI in clinical practice now for over 6 years. So I was a very early adopter. I've been doing it a long time. When I see headlines like recently in the Wall Street Journal about how AI can detect breast cancer, that's very old news for me. Of course, it can. I have practice experience with risk algorithm. So I have used it in clinical practice. I've seen the functionality. I understand how the scores work. So pretty solid background in the tech, and now I'm mostly focused on making it available, bringing down the barriers to access. I have a very early collaboration going on right now with Transpara, just for disclosure, nothing really too formal there, but the summary of my opinion on this is we got to make it more available. It just needs to be more available.
Oh, wait. So, hi, everyone. My name is Imran Farid, and I spent nearly 25 to 26 years so far trying to bring in medtech and innovation into systems. Some successfully, some struggled, and some technology that's still not been adopted yet. So it's fantastic to hear from Dora and Mark around the challenges that we face and the passion that this team has here to make this happen. Such as my passion to make this happen, I'm actually undertaking a doctorate right now to understand how do we adopt technology in breast cancer to create connected healthcare systems, and ultimately delivering value-based healthcare. And one of the key things that Mark, you just said, which really struck a chord with me here, is it's how do we get this into the hands of everyone and not in a few trailblazers like Mark who are really taking it on? Why is this not becoming the norm? And why are policymakers not making it, creating the systems and infrastructure to be able to adopt this and make it easy? So I'm coming at less from a clinical or an algorithm sort of development side, but more about how do we adopt innovation? How do we commission it? And actually, how do we scale this, that we don't get on a call in 2 years' time and say, yeah, 40,000 women died in 2026, but 52,000 died in 2028, when we have the ability, the technology, and the desire to change systems. And that's, what I think we all want to do. It's just how do we now scale that and deliver? And that's why I'm delighted to be on this panel and sharing some thoughts with no answers, and sharing some ideas with perceptions of how we can collaborate and move forward.
Thank you. Yes. So I have a few questions that I plan on asking these fantastic speakers for the next 20, 25 minutes, but the Q&A is open, and then we have some time set aside as well for any questions about the topics we're discussing. So I guess my first question for all of you is, we've touched on it a little bit, like AI has been around for a while. So AI for breast imaging, but then as well as other areas as well. But it has evolved dramatically over, the decades. If we go all the way back to look at computer-aided detection, so the traditional CAD algorithms that were developed, to AI that helps radiologists detect cancer more accurately, which I think is what Dr. Traill was talking about over the last few years. And now more recently is that AI can now estimate future breast cancer risk, right? So from your perspectives, what has been the most significant change, and what excites you most about where all of this is heading?
Well, from our perspective as a patient, and I would like to say it out loud, it takes so much stress out of the patient. For instance, going through this whole process on my own, it was super overwhelmed to understand from the moment I was diagnosed to the moment, the next, where am I gonna go with it and how am I gonna conquer it? Now, when we have opportunity to AI detect it, the human power is for professionals, doctors, and the medical staff to inform the patient, what's next. And that's huge. That empowers the feel of the patient from being uncertain, scared, and stressed to being empowered and being part of the process.
And what about Dr. Hill, from the clinical side? How have these algorithms changed, and where do you think this is all going to end up over the next few years?
Well, eventually it's going to be, I think it's going to be mandated. I
Mhm.
don't see how we can't get to that point because if you really look at the math, and this is all math, and it's very solid, it's very strong, and you just need to understand it to know what it can do. So I totally believe that down the road at some point, why it's taking so long, I have some opinions, but you're not going to be able to stop this. I mean, it's growing every year, it's expanding every year, the resistance is going down every year, and I think that the beauty of it is it's math. So you can plot all this out. You can have statistics and uh, things that really explain things in black and white. I mean, it can be very binary. And just so people understand, these algorithms kick off a score.
Mhm.
And higher the score, the more likely there's a cancer present, that'd be detection. The more likely patient's going to get breast cancer, that's the risk score. So you don't, and for risk in particular, you don't even need to look at the images,
Mhm.
right? All you need is the score. And what do those scores do over time? That's something now we're looking at too. So there's a whole new um, mathematical approach to all this.
Mhm.
Now, clearly you need human involvement. That's never going to go away. I mean, that's just silly to think that that's part of it. It's not going to run autonomous. It's never going to happen in the States. I can't imagine they ever allow that. Women don't want that. So, what I've seen over the past few years is a steady, widening of use, widening acceptance, although at a sometimes unbelievably slow pace.
Mhm.
And, we just got to go around the obstacles and get it out there, and we will.
Yes. And I think that's a good thing that you clarified too, is really detection tells us who has cancer today, right? And then prediction aims to identify who is more likely to develop cancer in the future, right? So before it's visible on imaging or clinically detectable. How do you see these two approaches working together to?
Well, I mean, the research I've done shows that the numbers are complementary. Risk actually does do a little bit for detection, and likewise detection for risk, especially if you're seeing interval change over time, which is something that hasn't been looked at too much until recently. But the FDA, as far as I can figure, when they approve these, it seems like they want them separated. I don't think the FDA, I think the FDA would like the risk to be used independent of the detection. I don't think they're going to clear it for any kind of detection function. So odds are, I think risk is probably best used outside a radiology department. I think it's best applied in a high risk clinic, or maybe some other avenue initially until people understand what this is. And the other thing is some of the pushback that you're seeing now from the radiologists is they're very, very busy. They're overwhelmed. I have people calling me every day to come work for them and, cover me for a week if you can. It just adds, if you're doing that, everybody that runs through the door, you're just overwhelming the system right out of the gate with a lot of people that necessarily might not want it. So again, if you kind of take it out of the radiology department and put it in the hands, say, of the breast surgeons, who actually I think are much easier to talk to about this, you're going to start the usage in a group of patients who are going to be the most likely to be able to understand what is involved and to be able to use it as empowering information, which it is. And so, yeah, I think they probably, my personal opinion is, even though they are, they do complement each other, that they're best used separate.
And what about the international perspective, right? How does this differ between the US and, Imran, some of the regions you have experience working in?
Yeah, so I think there's a fundamental macro shift here as well that we need to talk about. So when I look at the female population in general are more and more globally entering the workforce. Okay, so when we look at how economies are starting to grow within developing the countries that I've seen, um, women are becoming far more important in the GDP of a country because of the workforce conversation. But if we look at the detail of what's going on, more women are actually being missed in breast cancer, but it's one of the biggest killers of women between the ages of 30 and 49. And in a lot of the international communities we sit, um, the screening programs don't open up till they're 54. So it defies logic that the simple sequence of events doesn't tee up to help that. So when I look at when we want to create any type of industry, we see it as a GDP initiative, and guess what? Hundreds of billions can be poured into an industry to make job opportunity. When I look at this from a health economic perspective, I see the investment in breast cancer care no different to actually how do we grow economies. Okay, so, and that's not to take away from the emotional content of everything else. We need to talk about the system changes to make this happen. And when I look at that, the most significant changes from CAD, which was really a second reader tool, what we're seeing is it matched an image, it came up with some work, and sometimes, and probably Dr. Mark can explain this, but it probably added more workload for clinicians in an already stressed environment. Then came detection AI, and we learned models where we started to see some gains in sensitivity and consistency. But that wasn't consistent in its application across the globe. It just wasn't done. There was some great practice. Some people did well, but that created another question about equality and equity and who gets and who doesn't get, which I think is another fundamental thing that I'd like to discuss. Mm-hmm. What I think really starts to go is that if we get this right, looking at all the value-based healthcare and literature side of it and that cost equation, I think this starts to really start developing it. But what starts to really excite me here is that risk prediction. It's not asking if cancer's present in the image. It's actually saying who should screen, how often, with what technology, what we do. And it reframes screening from a uniform age-based experience type of conversation to say, who actually needs this in the healthcare system? Is this something that can be genuinely personalized in all over this? And that's what really excites me. It's about where we're headed. And exactly to what Dr. Mark said, the human element, healthcare is a human business, and we will never move away from that. And I firmly believe that all AI will do is it'll aid the healthcare systems to get more efficient, better, will give better access to people, improve outcomes and cost. But if we can truly structurally lever to personalized screening and prevention of cancer at population scale, that's what's going to be important, not just finding out what's there in a better and sensitive way. And I think what I'm seeing across the globe is that there is a move to create the right infrastructures now to be able to cope with the new algorithms and the new data and technologies. But as it sits today, the international, when I look outside of markets, the challenge is the same. There's a swell of patients who need to be treated. Women are wanting to be treated quicker, sooner, better, and faster. Nothing's taking away from that. And the emotional burden on families is the same, irrespective of the healthcare system you're in. So I think we all have an obligation to make this work and to make it better. And I think AI is one of those things that brings a tool to the table that helps us deal with some of the challenges that we face today.
Yes, thank you. I think that actually leads us right into the next question, is that, there seems to be a push from multiple different angles to have healthcare become more personalized, right? And I think this is especially true for breast cancer. And there's a lot of interesting guideline changes and other things changing, especially within the US around this. So do you think that imaging-based risk prediction will change how we screen women? And what needs to happen before that becomes the standard of care, or before in some regions there's even access to that type of technology?
Well, I'll go ahead and jump in on this real quick. Since I think it's going to be it's absolutely going to change how we do screening, because the math is the math and the performance is performance, and especially if you compare it to what we're doing now, which is TC8 for the most part. TC8 is a very weak risk prediction model. In some populations, in some Black populations, it's been shown to underestimate the prevalence of breast cancer. So it's a low bar. If you really want to look at the performance of TC8, it's a low bar. Mm-hmm. So displacing TC8 shouldn't be a big lift. What needs to happen? Well, the big hang up when I talk to people about using risk, typically, well, what are the recommendations? What there's no guidelines. So once they get guidelines down that are published, then that's going to move the needle, I think, significantly. That said, I think if you have, common sense and you look, if you have a high-risk patient from the AI, and you have a high-risk patient from TC8 or from their genetic profile, your options aren't that many. And what are you going to do? You're going to do what you did for the other high risk. You're going to do, maybe, and just making the other thing about this simply is that telling somebody they have high risk score definitely can go a long way in patient compliance, which is like baseline what needs to happen when somebody is high risk. And it doesn't always happen. It's very difficult for a working mom with 3 kids to maintain, an annual MRI. Yeah, that's where it's going to go. The organization, SBI and ACR need to get on board more, but yeah, it's going to happen for sure.
Yeah. And Dor, what do you think? Like, what needs to happen in order for this to just become standard?
Well, people don't adopt innovation simply because it's available. They adopt it when they understand it and trust it. So, for instance, before this innovation is going to become a standard practice, we need strong clinical validation, education, and for healthcare providers, and clear communication for patients. If, for instance, if women understand how this tool can help, they would make certain decisions. Adoption becomes much easier in many of those decisions making.
Yes, that's a good point. And so I feel like we spend a lot of time talking about the clinical benefits, right? And there's been a lot of studies out from researchers and clinicians about, how these are improving outcomes or have the potential. But AI also has major economic implications as well. So how do detection and prediction create value, for the patients, but also providers, centers, and even systems as a whole? And maybe Imran, this would be a good place for you to.
Yeah, sure. So if I bring in the value-based healthcare concept and from my own research that I've been looking at, this value equation, the outcomes over cost discussion, prediction really attacks the cost side. It really goes into it because when you can actually manage things better. So prediction can start even to the points that were made. It avoids over-screening. It avoids low-risk swimming and getting us to high-risk swimming. So it allows us to stratify a lot better. And that patient reported, looking at the treatment before it becomes complex and expensive, that's what this allows us to do. So I think the element of how we approach that from that, and it doesn't really matter to me which healthcare system you're in, right? Whether it's publicly funded, whether it's privately funded, it's still being paid for in some way. And everywhere around the world, healthcare is becoming unaffordable and it's unsustainable to grow the way that it is. So the more we look at this, we need to look at how do we treat sooner, better, and faster before it gets to a stage where we can't treat, or it becomes so expensive to treat that the system becomes strained as well. So I think detection to some of this where the AI would go, it sharpens the outcome side and the accuracy of what we find. But I think one of the critical things is there is no standard outcomes framework. There's nothing that says this is what we all agree good looks like, and this is what we all think is the best thing to do. And there are some outcome sets, like iCHOM have created some, and they need to be tracking things. But are we tracking the right things as well? And I sort of argue, not that it's right or wrong, that the patient being right at the center, choosing what the quality of life, the patient-reported outcomes burden across the diagnostic pathway, not just the diagnostic accuracy and isolation is important. So all of these things need to come in. And at that point, we make a proper discussion on why we should or we shouldn't invest in technology. If it's not adding any value, should or shouldn't we? And I think the patients have a huge role to play in advising what's actually made sense in the total journey, not in one isolated piece. And I think that's the conundrum of bringing all the clinical and the healthcare system together and saying the outcomes and the value being delivered, is it being measured and captured from all angles before we take a decision on blindly just accepting everything. And I don't think the systems can cope with the volume of algorithms and technologies just to be wildly adopted without a proper implementation framework based solely around the patients.
Yeah. Well, if I may add, from human perspective, the greatest value is peace of mind and potentially better outcomes. And that's exactly what you just mentioned, Dr. Arman Farid, if I pronounce your name properly. But also the earlier intervention often means less invasive treatment, less chemo, less radiation, lower cost, and better quality of life. That's exactly what you mentioned. So,
yeah, absolutely.
Yes. And the last question I have, and then we can open it up to anyone that wants to ask questions or we get anything else that we want to add, is, looking ahead, 1 year, 5 year, 10 years out further, what do you see being the biggest transformation in breast cancer care? And what role will AI play in making it happen?
Well, I'm quite happy to go on this one. So I actually think technology is further ahead right now than, but it's the infrastructure that stops it from becoming the standard of care. So I give an example of this. People talk about going, digital AI and connectivity throughout, and I've been in hospitals where you can't get a Wi-Fi signal. So let's not talk about connectivity just on the basis. There's a lot of infrastructure that needs to be put in. I think the first thing is validation. These models, as I think Dr. Mark just said, needs to be proven across a diverse population. And when I look at the markets that I work in, and I'm very privileged to work in all of these markets, the Arab population, the Arab gene pool, with the Latin American gene pool, with the African gene pool, and different comorbidities and gene pools that sit, some of these algorithms that have been created in one specific gene pool. So I think we have to look at that diversity of where that happens, not just in narrow cohorts, to get the maximum benefit. I think the second is a regulatory and interoperability groundwork. So what agencies now need to create the right mechanisms to make the adoption easy. Dr. Mark explained how two separate functions have been kept separately, and they might not look at that. The FDA might not look at that. Actually, is that the right framework that we're using? We need to challenge and critically look at that. And then, the third thing I really look at, which is central to what I'm really thinking about, is how do we actually buy these things? What is the framework? What is the outcomes based? And what's the evidence profile that's really needed to differentiate that and pay for that? And then the last one is trust and workflow. Clinicians need to see the risk score that's coherent, not in its working. And that comes into different theories like normalization process theory, etc., that we're looking at. But ideally, clinicians have to have the confidence that what they're talking about and it's delivering is something that they can stand behind and tell a patient that it's the right thing to do as well. So there's a whole element of things like psychological safety, normalization process theory, implementation structures, and all of those elements need to come together in order for those technologies to deliver. And I think it's not what happens or what needs to happen first. They all need to happen at this concurrent time to be able to get that going. Out with that, we get false starts. So some people will do really well. Some people will not be able to implement because they come up against a regulatory or an institutional barrier, or simply that Wi-Fi in some of the areas that I've been working in, it's not there. They still work on paper. And in some countries that we're in today, they actually don't have any infrastructure. So it's about how do you provide some level of infrastructure or access to healthcare. And I think that's the critical thing here. AI and digital gives people access to some healthcare that might not access any healthcare. And that's where I see the diagnostic capability of AI coming in. But all of it needs to go hand in hand. I don't think we can do one or the other and expect it to work.
And sorry. Dor or Dr. Traill, did you have anything about where you see the biggest transformations either happening now or you predict are coming up soon?
Well, I think Imran was very spot on. I think Dor has been very spot on. I think between the two of them, they've said the word trust 3 times I've counted so far. Critical. I mean, when I'm talking to radiology groups about adoption, that's the biggest hang up. And so, you pound the literature, you look, and then also if you're a user, you're always monitoring this. I mean, you do audits every month on your output. Sometimes there's some drift in scores, but it's not difficult to keep track of all the 90 plus detection scores and see what they ended up with. And, what I've seen, if you have a score of 98, well, odds are probably, 80% that you have a cancer without even looking at anything. As far as the digital part of this, what I really like about this is what I'm working on now, these are big data files relatively, the tomo mammogram, and that's one thing that the States does, almost exclusively now, that differentiates it from other areas. But it results in a big data set. So if you're looking at some kind of image sharing, you want to enable AI to a study that was done somewhere, anywhere, you've got to move that data around, right? We're developing lots of systems in the States for that. It's not a big deal to pull in somebody's, last 3 mammograms. And actually, if you're a doc and you request them, they have to send them. It's the law. So you can get a hold of those images. And then once you get the images, you can run the AI on it and give some information back to whoever is, wanting it. And the thing that I've seen too over the, repeatedly is I'll talk to a group of 10 radiologists, okay? 3 of them want anything to do with it. And if you ask them why, they just will say, I don't want to, you know? And then there'll be 3 there on the fence. And then there's 4, let's say, that say, give it to me yesterday. I understand this. I've looked at the data. I know how useful it is. I want to use it on my patients. So you got to get it in their hands. You got to make it accessible. You've got to have pathways where they can use it as they think they should. Doctors have leeway. They don't have to just follow everybody's guideline, especially when it's pretty clear, statistically and repeatedly with all the data now we're accumulating that this is what, you should believe the outcomes to be. So I think once, education, I do a lot of education, try to build trust, try to explain it to people. That needs to happen. And I think another strong tool here, and this is, Dora is part of this group, is, women advocacy groups, survivor groups love to talk about this. They love this. Now, are they going to understand?
100%.
Huh?
100%.
Yeah,
Yes.
no, and so, what I want to do is get it in their hands. Let them spread the word. Let them get access. Let them get it to their sisters and their daughters and whoever else. Bypass the hospital that's going to sit there and wait for, reimbursement and widespread guidelines that, we're looking at years. So people can understand this independently. There's a lot of really smart women out there. They can look at it for themselves and come to a conclusion whether they think this is going to be benefit to them or not. And, risk isn't just what the mammo says, it's what the patient thinks. Some people say, I'm not going to get breast cancer. I'm not worried about it. Well, I don't know if you want to make them go into a lot of screening if that's, it's like investing. I'll buy SpaceX, some people wouldn't touch it with a 10-foot pole. So there's that part of the risk too. But making it accessible, building trust, educating are very important steps need to be taken.
Thank you. And Dor, did you want to wrap us up with your perspective of what you see coming?
Well, absolutely. I hope the future isn't about smarter technology, but it's also more human healthcare, just exactly what we're talking about, educating clinicians and making patients more confident, what's happening in the world, what's happening with diagnosis, where are we going with it, making this whole process preventative and full of empathy and trust that remain at the heart of medicine still, because that's the core of it. Patients need to trust, clinicians need to trust that human healthcare with AI, beautiful support, and amazing technology.
Thank you. So thank you all for joining. I really feel like the conversation's ending with trust is the #1 thing that we all need to focus on to start. It seems like we all agree, though, that these type of AI technologies are coming out, and it's just how do we build that trust and the infrastructure around it to really reach the patients and the doctors. So.
I trust it.
You trust him. Dr. Traill trust it.
I do too, as a patient. And boy, oh boy, what would I have done if this technology would have been available in 2019 and I was diagnosed? There would be a whole different world for me, taking 2 years away from me because of stress level, uncertainty, and where I'm going to go with it. So now the women and men as well, because breast cancer is actually not only women related, have a huge opportunity in life to release that stress and move on with life in a better quality of life. And to me, 2 years of my life, it was taken away because of lack of this opportunity.
Thank you.
Let me just qualify. I want to say I trust for the risk. It's very good at predicting who might get it. I would be very cautious about telling somebody they're not going to get it. I mean, I just don't like to tell people what can't happen. That just doesn't seem to work for me. And, so I think you need to take negative or low scores with some caution.
But
It's reassuring. And if you have a score of 1 out of 100, that's probably, pretty solid. But still, I don't like telling people it's.
Yeah. I think just to finish up there, I think what you said there, Mark, is absolutely spot on. But I think rather than going from a single point of screening and then you're okay and your risk score is great, I think looking 5 to 10 years out, I think what we look at is this continuous multimodal risk profile that allows people to take control of their own. So even though they may be 1 on a risk score and 100 on another risk score, they have the evidence. It's not a one-time event. It's about how do we look after our health in general. And this can be applied to any comorbidity or any disease or any. We can take control of it as long as we know and we've got the systems in place to have not a one-time event to say you're good. Now you don't have to come back for 5 years, because it doesn't work like that. Let's make, I think, the ability to use these infrastructures, all the trust and everything that we're talking about, but actually empowering people with the evidence and with the data, which is hugely available and underutilized as a resource, so patients and people and clinicians can take really informed decisions on what does that mean. And I think that's the beauty of when I, working for Alliance Medical, what we're trying to do is to create longitudinal data sets to allow people to have access to their own information and make informed choices with their clinicians about what they should do, whether that is simply saying, you need to go to the gym and do exercise, whether that's walking, cycling, weights. It's entirely the patient's choice, but let them have the information, and it's not kept in Excel files or servers that they can't access either. And I think that's the beauty of what AI can do, what digital can do within this concept. Give patients the power to take charge of their overall outcomes and what they want in life as well.
Well, thank you all very much. And then if there's any questions, we're happy to follow up through email as well. So if I find anything in the chat, I will make sure it gets to the right person. And thank you so much to all of the panelists.
Thank you very much.